Chairman, sirs, and the audience, good afternoon. My name is Abhijeet Wahegaonkar, and my task is to speak on management of distal radius malunion. Thank you to the BOS committee for the opportunity. Here's a case. Is a 32-year-old right-hand male accountant who came with a deformity of the left wrist, and he had a fall, complaints of weakness of grip strength, reduced range of movement. He is otherwise healthy, and he had some percutaneous fixation with casting that was done. The clinical findings are listed on this. I won't belabor too much on this, and this is how his hand looked. Doesn't take too much of rocket science to understand what's going on. And then, just like Rohan mentioned earlier on, if we fall back to the normal x-rays and the angles and the measurements, this obviously does look different. This shows that there is something amiss, there's something going on. And then at times you would want to get a CT scan done. And if you look at the ulnar corner, you would understand there's something going on in the coronal plane. So the sagittal plane shows a little bit more with that intra-articular step off. And then also, we should never forget the ulnar corner. A lot of these patients will present with a DRJ instability. Either there will be an ulnar positive because of the subsidence of the radius, or a DRJ instability. So, what is the diagnosis? What is the plan? We'll come to that based on the discussion that we'll quickly run through on these outlines. So, distal radius malunion can be as high as 17%, and the highest rates are those in untreated, surgically non-treated fractures. And the effect of the malunion is on the wrist kinematics, and several studies have reported on this. And the first treatment of malunion was that by Gormley and Morse, and then it was popularized by Campbell and then by Diego Fernandez. This paper talks about the acceptable limits, whereas clinically the patient will present with either a cosmetic deformity or, of course, several different aspects of the function getting compromised, right from wrist pain to loss of grip strength, and sometimes even a paresthesia because of median of compression. Now, we always were taught about, we grew up with thinking elderly people may tolerate deformities very well, but we all know now that there is an increased life expectancy. Even the senior population is independent, so they too deserve nothing but the best, or at least a meaningful usage of their hand. What happens in the malunion is that there is shortening of the radius, there is distortion of all these angles, and there are intra-articular irregularities that need to be identified. And the angulation results in a carpal instability, which is often referred to as the adaptive instability. Shortening causes a dramatic change in the radiolunate contact area with a relative ulnar positive variance, which leads to a ulnocarpal impaction, and radial inclination loss will shift the loads to the scaphoid further. So all of these are precursors of a degenerative change that can occur very quickly if left untreated, or if not identified and treated. So the workup will obviously begin with a clinical examination, looking at the contralateral side, getting good x-rays that we all talked about, and then CT scans. And the indications for correction are listed on this slide, and obviously they would include all the functional disabilities that the patient will present with. Watson looked at the indications and contraindications, and he concluded there are no absolute kind of contraindications. So taking into consideration all of these factors, you can provide a good outcome with corrective osteotomies. The prerequisites are, of course, absence of any degenerative change either in the metacarpal or the radiocarpal joint. There should not be any trophic changes. You should have a good and supple hand, and the patient has to understand the outcomes and the therapy that is required. Surgical planning usually consists of 4 parts involving the osteotomy per se, grafting, fixation, and then if any ulnar-sided procedures are required. Approach could either be dorsal or volar depending upon the malunion and depending upon what you want to address. And then the osteotomy could either be a closing wedge or an opening wedge osteotomy. The opening wedge osteotomy is the more commonly performed procedure with several advantages, and the disadvantage being a temporarily unstable construct which usually requires bone grafting. And again, this was a technique that was first described by Diego Fernandez and then is pretty popular now and is perhaps one of the most commonly performed procedures. Schematically, this is how it is performed. We usually require a strut graft, a trapezoidal wedge graft, to not only provide structural support but also to correct the deformity in all planes. And here is a case in point wherein a corrective osteotomy with fixation, and like Pankaj rightly said, the fixation can very well be on the volar side. A percutaneous osteotomy can be done to open out, and then the bone graft can be put in. Regarding bone grafting, we'll again come to that in a little bit, whether it's absolutely necessary or not. Closing wedge, of course, again, there are advantages and disadvantages that are listed out here. I won't belabor too much on this. Again, several studies. This paper from Japan by Takuro Wada is one of the most frequently cited papers, published in JBJS 2011. And again, it has its own advantages and disadvantages. There are certain variations of the osteotomies, such as the sliding osteotomy, or the Watson and Castle trapezoidal. I'm sure all of you must have seen this in several textbooks and journals. Bone grafting is recommended. Is it absolutely necessary? Well, there are substitutes also available, but this particular paper talked about a meta-analysis wherein they demonstrated that corrective osteotomy of extra-articular malunited fractures can be treated with a good fixation, stable fixation, and then bone graft is not necessarily required. Fixation, there could be either external fixation used as a definitive modality is perhaps not a good idea. Internal fixation historically is the preferred modality of fixation, and you have different configurations of plates that have been described, and there are newer advances in the design and the metallurgy, and just like we heard from Dr. Warrior, we have several different designs coming in which are now more appropriate for such procedures. A quick word about ulnar-sided procedures. This is usually done after you have corrected the malunion. You check the DRUJ for instability, and then you resort to ulnar-sided procedures. The options are listed here. I won't belabor too much on this. So again, coming back, remember our patient, he had this malunion. These were the findings, and here is the procedure in progress. You can understand that the X-ray on the right-hand side shows the concept that this may be unstable for a little while. You may use supplementary external fixation, bone grafting done, all parameters restored, and then you check for the DRUJ instability. More often than not, the DRUJ renders itself stable after you have restored all the parameters in terms of length and inclination of the distal radius. Every now and then you would come across such patients, malunion that was quite bad. CT scan helps us a little bit more, and again, corrective osteotomies and fixation with the so-called variable locking rim plate, and then the outcomes can be pretty rewarding. Sometimes we may have very distal dorsal malunions, and Pankaj has already spoken about this. The use of dorsal plates can be pretty handy in such cases, and then again, reasonable range of motion can be restored. Quick word about salvage in patients who present with degenerative joint disease. Some kind of a partial or a complete refusion may be required. Here is a case in point. Arthroscopy helps a lot in determining the articular surface. This patient also had some ligament injuries, and the cartilage loss was quite significant, so we decided just to go ahead with a complete wrist fusion. So with that, I would like to again thank the BOS for the opportunity. Any questions? I'll be happy to answer. Thank you.
Thanks, Abhijeet. Any questions?